So I think this last session is arguably the most important session because the way we interact with clinicians and now with patients is through the radiology report. So the report that we create is critical. And so this whole session is sort of reporting, what sort of terminology we use, what are the other systems we can use to create a report. So we're going to start off with my co-director, Dr. David Naeger, with his topic of dictating like a pro.
All right, thank you very much. Yes, as she said, I am here talking about the actual dictating part of reports. Again, I'm from Denver, head of radiology at Denver Health. So this whole segment is about the report, and so after me, we're going to talk about structured reports and the words that we use from the Fleischner glossary, a little bit about AI. So the first question is, why are we having a lecture about putting together the report? It turns out it's really important, right? This is actually our main product. Yes, we find diseases and make observations, but we have to communicate them, and this is the record. And actually, there are errors all over our reports, so this is an important thing to address. And in training, you actually get very little training on it. So that's why we're talking about it. So I will highlight to start that it is a somewhat controversial topic, right? We actually have some really fantastic chest imagers here, and we might not all exactly agree on style. So this is sort of some common suggestions. Maybe I'm representing chest radiologists more than others. While you're in training, you will probably have to adapt to the people you are working with and their style. The good news is it lets you see different styles, and you can pick your own when you're done with training. All right, so we're going to go through parts of the dictation, style, and accuracy. Okay. So first, the parts of the report. If you think about a classic radiology report, it has headers. It's true between all of our institutions. Probably looks something like this. Okay. So let's go through each part. The study type and date probably imports automatically in a template. It can occasionally be wrong. It's worth maybe a quick glance. The history will also import generally in most places, but it's very important to make sure this part is correct. So what is in your history, the sort of signs, symptoms, and indication, is part of it going through the reimbursement and coding cycle. Okay? It's also what indicates if there is a medical legal problem, the information that you had available to you when you were interpreting. It's important, therefore, to make sure it's clear. So if it has a bunch of abbreviations, especially if ambiguous, we should fix them. If you learn more, you can add to that history. It's not required to only leave what's imported. And if it has some junk in there that's not needed, like approved by or here's my pager, you can take that part out. Okay. All right, next is technique. This usually is built into your template, but sometimes we have versions of techniques. If the study changes, you have to make the technique match what was actually done. Okay. Next is comparisons. This is anything you compared, even if it's multiple. It's not just the most recent, okay? Sometimes this happens automatically, listing your comparisons. Radiation dose is only at some places, okay? Some states, for example, so you may or might not do that part. And then the last is findings and impression, and this is the meat of the talk. This is the important parts, okay? And I do have one very important take-home, if you're just going to clear one thing from this lecture, which is this first point about findings and impression. So let's say this is a report. Here's a finding and impression. Notice anything? Like it is suspiciously identical? So that is tip number one. The impression goes in the impression. The findings goes in the findings. Okay? So it is not supposed to be a copy and paste. Now there is one small exception. If you're going to say in your impression what you think something is and what needs to be done, you have to make clear what you're referring to. So that requires at least briefly reintroducing a finding, so then we can give our impression of that finding. Okay? So why does this happen? I think when we're dictating and we're in findings, we make an observation, sometimes our brain immediately goes to, and what is this, and what should happen next? So then we want to keep talking. So how can we fix this? One option is to give your finding, then click down to the impression and just keep on going, okay, and put it in the right place. Then click back to your findings section and you can keep on going, okay? Now, why do findings end up in impression a lot? I think because it's too easy to copy and paste, right? So you should not take the full paragraph of findings. It needs to be a more concise summary. All right, and then last after findings and impression is if you did communicate the report, you are actually supposed to mention multiple pieces of information, like who, when, what you said to them, if you communicated, okay? And if it's a non-provider, you should indicate that they are allowed to take the message and they read it back. All right, so the summary here is make sure they're all right. Findings goes in findings, impression in impression, and you should document communication. All right, style. Here are 3 lines that maybe we would see in a findings section. What do we think about it? My thought is, there is adding nothing, okay? Now this point's particularly controversial, but my personal opinion and others is you can just drop the there is. Right? I'm actually a fan of sentence fragments because it contains the data and drops unnecessary words. Now, some people feel very strongly that a full, complete sentence is needed. I do not, and that is not how I dictate. So my advice, no sentences or few. Next, here's another set of lines from a findings section. I'll let you read it. All right, my observation here is this one has lots of what I call connector words, right? The although and as well. And my thought about these is these are not needed, right? And in fact, if anything, they could be confusing. Are we sure the lymphadenopathy connects to the pleural effusion? Maybe, maybe not, right? And this brings us to the point that this is not an essay. Right? I think we're all very educated people. We want nice reading, writing. We'd like to read the newspaper and an essay to get into college. These are dictations. This is about data. Okay? So we're actually using words to convey data, not telling a story. So what that means is you can remove the connectors because they don't help. Okay? And in fact, if we think about this further, this data-driven report, I broke down that paragraph into different parts. What is the actual data in here, right? It first is a location, a finding, and relative adjectives, right? We did choose in that to mention the other side and say it was negative. We mentioned an abnormality of lymph nodes. And in that, my example, we mentioned another negative. So these are the keys that need to be in there, right? The other words actually aren't adding anything. Now, I'll point out here, this is where there is a little bit of art, okay? Because we actually made choices about what goes into that, right? So the first part's straightforward, but do you need to mention the right if you talked about an abnormality on the left? Is it just implied? If you say lymph nodes, do you have to talk about other lymph nodes? And then when do you have to mention a complete negative, like no effusion? There is some art here about what's included, particularly in negative. So let's talk about that for a second. So the positives, something's abnormal, anything that could be clinically relevant, change management, should be mentioned, right? So that part's, I think, easier. When and how much negative is actually a sort of choice. So the guiding principles here are if it's relevant, helps with the differential or the main questions asked. There is a component of completeness, right? You can't put together a chest x-ray and not mention the lungs, clear or not. But maybe you don't have to mention a miscellaneous outline that looks normal of an abdominal organ. So what is complete per study type? And then overall, what is the best way to make sure we're not writing an essay and putting together a data-driven report? That is actually our next talk. Structured reports is one way. Generally short, data-driven sentences. I even use commas or semicolons to drop the words and make the data more dense. All right, so next is think about your findings section as delivering data. Next, here's an example of findings. I'll let you read it. This is very wordy, right? There's a shorter way. In fact, a line and a half has every single piece of data that white text did, right? So connect together, and this takes practice, learning how to concisely say something's gone and new and where it is, commas, but there is a way, so I'd encourage you to practice, okay? So drop unnecessary words. My favorite example is actually when I checked into an Airbnb. This is what was attached to the television. So this whole thing is like wasted words, right? Sentence 2 is totally separate. Where else are you going to look at them if not on the screen? So we can drop one sentence, and in fact, high definition was repeated. The entire content there is 5 words, and you can use 6 words to make a sentence. Okay. So that's what we should be doing, but we actually have a tendency to go the wrong direction, right? We love adding nouns to sound smarter. So instead of right-sided, it's just the right. We also love taking nouns, turning them into an adjective, and then putting a nondescript noun after it. This could be an infection or fibrosis, right? Emphysema. You can also drop numbers if you only have one. Okay, and then one sort of special case is evidence of. Some people use this a lot. We're not actually looking at things with our eyes directly, but we see lymph nodes, right? It's not evidence of lymph nodes, so you can drop that. We should use evidence when we're implying a physiology we can't see, like ischemia, for example. Okay? So the trick here is to be concise, okay? Drop unnecessary words, use simple words, commas instead of words. Next in style, what do you think about this findings or impression? I don't even know what all these letters mean. That's a lot of abbreviations. So they do not belong in an official report, okay? No abbreviations. And lastly, well, people are laughing, so I guess it's not that great. Yeah, so we got some problems here, right? So we'll start with yellow. Yellow, we are insulting the patient. The orange, we're actually insulting ourselves and our own product. And then the blue, we're instilling some sort of emotional valence to what's going on. So you should not insult the patient, especially now. They actually can access all of their reports word for word. You don't want to insult your department's work. Maybe a study is limited. Maybe there was an issue. But we don't want to say that it's bad or poor. We made the study. Okay? And then lastly, we don't really want an emotional component, worrisome, concerning. You know, it is or is not, has a different likelihood of a disease. Okay. All right, so there's our summary for style. And then the last one is accuracy. Okay. I've seen this all the time. I've accidentally signed reports like this. It's for lymphoma. Totally wrong history. Why? Probably because it was typed in wrong or they confused the patient. You want your report to be accurate. Okay. Next, what if this was a findings and impression and this is all that was written about some pulmonary nodules? We have no idea what's going on, right? What is actually happening? No idea. So then this brings us to the question accuracy about what information you do need to have in a report, right? And for nodules, it's not actually a small amount, right? We need the size and multiple details to actually get a sense of, ultimately, what is actually going on, the impression, okay? So for example, tiny nodules, unchanged long time, no problem. Large, round, new, measuring up to a size. Maybe that's metastatic disease. Or if we have them irregular, different sizes, maybe this indicates something that's an infection. We come up with an impression here, but not if we lack the details. So I'm a big fan of concise, but you can't be too concise by not including key info, okay? So don't do that, please. Next, what do we think about some of these words? These are radiology classics for non-specific, right? Stable means two things in MSK. Changes means nothing, so let's use a real noun like fibrosis. Clinically correlate to what? And is not excluded usually means is a less likely possibility, so we can be clearer. Thoughts on this? Yeah, we got some issues here. Mostly dictation problems. Maybe we got to write left wrong. So this brings up the issue of proofreading. Do you need to proofread? Can you just said, I'm sorry, PowerScribe made it. It might be wrong. No, you can't do that. You have to proofread. Okay, so yes, it matters. And lastly, if you are assigning and attending as a trainee, try to make sure it's the right one. It's otherwise irritating. So that was accuracy. So we've gone through parts of the report, making them accurate, findings and findings, impression and impression, document your communication. We went through some style advice, mostly about being brief and data-driven. And finally, make sure reports are accurate, don't be too concise, proofread, and details matter. So that's it. Thank you very much.